We've gone through the first couple of questions from a physiologic perspective. Is there an obstructive component to their shock? Is there a cardiogenic component? Then we asked ourselves, okay, it doesn't look like it's one of these, or it's not primarily one of these. Is there a hemorrhagic source? And we looked at those. And now we're going to look at, is there an identifiable infectious source? Now, you may not always identify the infectious source, and it could be kind of hidden, but in some literature we've seen that we can identify the infectious source or cross off other infectious sources in a significant number of our patients. And again, we narrow that differential, we decrease our cognitive load, we can focus our management and our treatment of that patient. So we'll look at a few of these infectious sources and what they could look like. In the lungs, so we could have something that looks like pneumonia. What we see here is a lot of irregular, ragged looking chest pleural interface. We see a little bit of pleural fluid and lots of B-lines and irregularity. So this may go along with a diagnosis of pneumonia. Obviously, we're going to look at the whole chest. When we look at the abdomen, we may see some signs of obstruction, which could lead us to suspecting, this is not definitive or confirmatory, but it may help us suspect a complicated UTI as a source of infection or other renal failure, because a lot of these patients in shock may have renal insufficiency or an acute kidney injury. The intra-abdominal things, these again, more things that have surprised me and helped me more than I would have anticipated, but we can see these inflammatory changes. So here we see this thickened bowel wall and this bright white inflammatory fat around it, and here we see even a diverticular pouch, so a diverticulitis that could be a source of sepsis. A small bowel obstruction, which not necessarily by itself is an infectious etiology, but it may suggest an intra-abdominal component or complication to their causes of shock. A complicated appendicitis, so we see this is just a huge appendix with lots of inflammatory change and fluid around it, very complicated looking, but just kind of general intra-abdominal inflammatory change that may again suggest an intra-abdominal etiology. And I'm not going to suggest that you're not going to CAT scan this person, you probably are, but when you walk out of the room and you say, this looks intra-abdominal, we're going to start appropriate antibiotics to cover an intra-abdominal source, and our differential is shortened. This is a very helpful scenario. And then don't forget the skin and the soft tissue. Now this is going to require, a good physical exam, including don't forget their backside. And what we see here, this is an example of necrotizing fasciitis, where we see these bright white little air flecks. These are bubbles in the soft tissue, and this streaking dirty shadow artifact that is indicative of air in the tissue. And a diagnosis of a simple cellulitis versus a potential necrotizing infection is a drastically different diagnosis, and the management plan is going to be different. Just a few more examples. This is pneumonia. So we see pleural line, a big subpleural lesion with B-lines all around it. There's some little air bronchograms in here. Some more intra-abdominal processes, small bowel obstruction. This is an intra-abdominal abscess. This one was again related to ruptured appendicitis. Another example of skin and soft tissue infection here. All these bright white things are air bubbles, and all these streaking artifacts are from the air in this necrotizing infection in the groin. This is an acute cholecystitis. So this is the gallbladder with a thickened wall. Looks like a little bit of pericholecystic fluid. There's a stone in here. So a lot of these intra-abdominal things we can identify with ultrasound if we take a reasonable look in their abdomen. This is a renal abscess, so this is all kidney here. And this, if you weren't sure about this, put color on it. You're probably going to do further imaging on this, but this may help guide your initial decision making. So those are some of the infectious things. There's more, obviously, that's not the end of it, but some of the things you could find when you're evaluating your patient in shock. And again, a lot of times you're going to be doing this when you first history, physical, and a guided ultrasound to identify physiology and etiology of shock. And just like everything we talk about, a lot of these things could be chronic and may only be a complicating factor and not a direct etiology. A lot of the left ventricular failure, right ventricular failure, those things could be chronic and they could be just complicating the patient in shock, or they could be secondary things. Some of these fluid collections, like patients can have chronic pleural effusions or chronic ascites, even chronic pericardial effusions that are a little smaller. They can have a chronic abdominal aortic aneurysm. All these things are findings that you have to interpret in the context of the entire clinical picture. But sometimes the findings may lead you to ask more questions that will clarify things in this patient's case.